So our next speaker, Benjamin Sansom, a PhD candidate and an intensive care registrar at Royal Melbourne Hospital. Benjamin's going to present low blood flow, CVVHD, reduces alarm rates during CRRT. Thanks very much, Benjamin.
Good afternoon, everyone. My name's Ben Sansom, and I'm an ICU registrar and clinical researcher at the Royal Melbourne Hospital and the University of Melbourne. Today, I'm presenting my research in renal replacement therapy and looking specifically at the hemodynamics of renal replacement therapy and alarm rates during CVVHD and CVVHDF. Is it this one?
The green button?
Green. At the top.
Big green button?
Oh, yeah, sorry. So I like this quote as it highlights one of the big problems in intensive care. Some of you may have seen this before. It's from Dan Airley, Professor of Psychology in the States. And essentially, we're sitting on huge data sets these days, and they reckon about 80,000 measurements are made and recorded continuously in patients in intensive care. And there's this huge wealth of data that we're now collecting, but a lot of it's untapped because we don't necessarily have the skills to tap into it fully and appreciate the insights that can be provided from big data. So I'm going to talk a bit about big data and CRRT today. And this is the background to my talk. CRRT is a complex system, as you can see here. There's multiple interactions between physician and patient, physician and nurse, nurse and machine. And one of the places where huge amounts of data are recorded are in the CRRT machines themselves. And some people may not be aware, but these machines will record continuously pressures, flows, and scales data. And that gives us a lot of insight into how the machine is functioning and also, the impacts the patient and access may be having on the machine, as well as things like anticoagulation. So we know there's an increasing incidence of AKI, and CRT is growing in intensive care, and it's one of the main forms of multiple organ support that we provide. Circuit life has been reported to be 20 hours, but in situated circuits up to 38, as the GATA study showed. But failure is still a significant problem with blood loss, nursing time and attention, and significant clinical and financial costs associated with this. Additionally, alarms particularly are time-occupying, and CRRT alarms contribute significantly to this burden. And if you ask nurses, they often complain about this, that this is a big problem. So coming to alarms in general, the purpose of an alarm is to alert the staff in a change in patient status. Now, we know they're an important safety mechanism in intensive care, but have a high false positive rate, with studies showing that 70 to 90% of alarms may be false positives. And this can result in this sort of alarm fatigue and boy who cried wolf phenomenon, where we actually miss the true problem. And so we get this balance between, is it better to be safe than sorry, or are we going to miss things because we're ignoring the alarms because they're going off all the time? And so how do we strike this balance? And what can we do about the cacophony of alarms and rampant fake news? Well, we can reduce the propensity for alarms by improving treatment, thus improving the overall alarm rate, or we can reduce the alarms by making the alarms cleverer and more specific. So, moving on a bit more about alarms, alarm fatigue is not the only problem with alarms. And one of the big issues is, and the focus of this conference being holistic care, is they are scary, they are disturbing. Patients don't like them. I can't imagine what it's like to hear these alarms going off all the time when you're critically unwell, especially if your loved one is unwell. And they disturb patient sleep, with this study from Australia showing that the median duration of sleep in intensive care is just 3 minutes, which is incredible when you think about it, 3 minutes of sleep. And that's particularly due to noise in intensive care, which is predominantly down to alarms. Now, alarms have features of a human scream, they're not nice, and there's a confirmed link between noise in ICU and delirium, which we know is a really negative impact on patients. So existing studies in CRRT mainly focus on circuit patency. There's limited studies in circuit hemodynamics and non-anticoagulant factors, and there's limited reports on alarm data. And to my knowledge, no reports on alarm data in CRRT have been published. So just to remind you, this is the CRRT circuit in general, obviously different in different modes, but we have blood coming out of the patient via a vas cath. An access pressure is then measured, that's a negative pressure. The blood pump pumps the blood through the circuit. We then have a pre-filter pressure, which is measured before the blood enters the hemofilter. And a return pressure is measured when the blood returns to the patient. Now, we also have an effluent pressure, which is measured on the effluent side of the hemofilter. And this obviously varies slightly with replacement fluid and dialysate depending on the mode that's used. But that's the basic extracorporeal circuit. Now, the other pressure that we measure is actually implied by the other pressures and it's calculated. It's the transmembrane pressure. So that's calculated from the pre-filter and return pressure and effluent pressure. So the objectives of this study were pretty simple: to describe the circuit hemodynamics in simple terms in 2 modes of CRRT, and to establish the alarm rates in 2 modes of CRRT. And this was CVVHD at low blood flow and CVVHDF at a higher blood flow. So this was an observational, single centre, before-after retrospective study. Ethic approval was provided. Data extraction software was developed by myself, and analysis, or statistical analysis and graphing was performed by myself in our software. Pressure scales and events data are recorded continuously during therapy as part of routine care, and minute-by-minute data was extracted from these data cards. The 2 modes studied, in the before group, we had CVVHDF, which was our standard practice at a set blood flow of 200 to 250 mils per minute, with a standard effluent rate of 30 mils per kilo per hour, of a mixture of CVHD 50% and filtration 50%, with mostly pre-dilution. CVVHD was then the after state, and that was at a lower blood flow to try and reduce tension on the access catheter, and that was set between 110 and 130 mils per minute, generally towards the 130 mil per minute blood flow, and the effluent rate was maintained by increasing the dialysate, and a small amount of post-dilution was included to prevent clotting in the duration chamber. Pressure variables were analysed graphically, and frequency of alarm rates were measured, including advisory, caution, and warning. So, looking at the results, this shows the circuit life in hours down at the bottom, and this is a sort of a curved histogram. And you can see the curves are very similar, so very little changed. We observed almost 1 million minutes of continuous data, 771 circuits were observed, and the circuit life was not significantly different between groups. Now, when looking just at the early failing circuits, however, just the first 12 hours, we did see some benefit in CVVHD with 90 minutes of extra treatment time. But interestingly, this is the pressure effect. So some of these would be expected findings. In the bottom right-hand corner, you can see the access outflow pressure, moving around the pre-filter pressure, the effluent pressure, transmembrane pressure, and return inflow pressure. Each of these are curved histograms showing the pressure along the x-axis and a sort of frequency along the y-axis. And this is all the 900,000 odd minutes recorded. And you can see the CVVHD curves are all the blue, light blue ones, and the dark blue ones are CVVHDF. And you can see the general trend I'd like you to observe is that broader, more varied pressures in CVVHDF at a higher blood flow, so more variability, which we'll come to later, and a taller peak in CVVHD at a lower blood flow, so a higher concentration of pressures in a single area. Now, this is the pooled alarm rates. Looking at the total hours in CVVHDF, we had more than 10,000 and 6,000 in CVVHD at a lower blood flow. The thing I'd really like to draw your attention to is overall alarm rates were reduced in CVVHD, but the warning alarm rates, which are the most significant, the ones that need the most attention and immediate response, were reduced significantly by 46%. And this is going from an alarm every 22 minutes in CVVHDF to 1 every 40 minutes on average in the aggregate data set. And if we look at this by circuit, we see that CVVHD circuits had a warning alarm every hour, whereas CVVHDF, 1 every 45 minutes or so, and this was statistically significantly different. Now, multivariate analysis was performed, correcting for access site, age, weight, ventilatory status, and this showed the only significant difference was the mode, with CVVHDF having a 2.8 times additional risk of a warning alarm and confidence interval between 9% increase and a 550% increase. and that was statistically significant. So in conclusion, changes to blood flow and CRRT mode clearly have measurable impacts on circuit hemodynamics, as I showed with those charts. Lower blood flow CVVHD was associated with significantly fewer alarms, with a 46% reduction in overall alarms per hour of therapy. Higher alarm rates may relate to increased pressure variability at the higher blood flow. And although circuit life was similar overall, these findings may suggest fewer nursing interventions are likely to be required with a lower blood flow treatment, and our patients may be benefited by lower disturbance from ongoing alarms. This study has a few strengths. There's one of the first use a large data set to quantify circuit hemodynamics and alarm incidents. It's a granular data set with minutely recordings, and all occurrences of an alarm will be recorded. And it's real-world data in a mixed ICU cohort. Limitations are its observational retrospective status, and no citrate circuits were analysed, which is a real limitation. These are all heparinized or heparin protamine or no anticoagulation circuits. It's a relatively limited analysis for what could be done, and future data mining will be undertaken with this large data set. So my key points are these modern computing techniques, which are becoming increasingly available, allow us a new paradigm in computational physiology. I think I've demonstrated the ability to analyse continuous hemodynamic variables within the CRRT circuit. I think I've shown that a practice change can be implemented and an impact measured, and impacts on clinical process improvements may be seen, and that warning alarm rates significantly reduced in a lower blood flow CVVHD versus a CVVHDF at a higher blood flow. These are my references, which I've gone throughout, and I'd like to thank my supervisors and colleagues who've helped me. Thank you.
Thanks very much, Ben. We could now take some questions. Yep, I see a hand up at the back there.
Hello, Doug Stenhouse from Ballarat Base Hospital. Very interesting study. I find our main paradigm shift that we've, in our practice at Ballarat Base, has been the use of citrated circuits, which have made a huge difference in our filter life. Also, the blood flow rates are a standard rate of 150 with our citrated circuits, which reflect that data. Also, since then, with the heparinized circuits that we used to run, we're at a higher flow rate. So that would reflect what we've seen in the studies. That with that lower flow rate, I think we get less negative access alarms. But probably the main paradigm shift has been that change to citrated circuits, which, with the lower flow rate, have led to less alarms, but also much extended filter life and much less clotting of the circuits. That's been our main change.
So yeah, I agree completely. And citrate probably has multiple benefits, including the ability to go at below blood flow rate. Traditionally, we've had high blood flow rates because of the high, coagulability of the blood. Even with heparinization, the blood tends to clot in the filter. But citrate seems to allow a much, much lower blood flow and much more stasis within the fibres, which means you get less issues with access dysfunction. So that's the next step, actually. We've switched to citrate now, and we're continuously measuring. So what we've done is kept the blood flow rate the same as in this study of 130 mils per minute, and moved to citrate. So we've just made a single change to move to citrate, but we have moved to pre-dilution to use the citrate. And so we will now see exactly what the hemodynamic effects are of citrate and how they compare to pre-citrate at higher blood flows and also at the lower blood flow rate, CVVHD. So, yeah, no, I agree. Citrate is clearly the thing we have the most evidence for providing benefit. There's no reported evidence on alarms, so that will be, we'll study that next. It may be an even greater improvement because most of the alarms we face are usually due to access or return pressure issues.
Yeah, just rather than changing practice according to the manufacturer's alarms, have you had any thoughts about a conversation with the manufacturer to make smarter alarms? For example, resistance and flow are linked by flow and pressure are linked by resistance, and it may well be that's actually a much better metric to record and set an alarm by than the pressures and flow per se.
So I completely agree that the future is smarter machines, and actually a lot of it can be done with software. We can measure things like the transcatheter resistance to flow using CVP as well, and I think the future is that we will be able to get resistive indices and change and have the machine auto-regulate certain things. So when the pressure becomes too high, auto-regulate and slow down, for example. I think a lot of the future is actually in liaison with the manufacturers and improving the software side of things with this data.
Yeah, I'll a quick question myself. You may have said it, but was the dose at the 130 mils, was the dose still 30 per kilo that you're using? Was it all, and it was all post?
The dose was maintained, but it was almost purely through CVVHD. There was some filtration. There was 200 mils of post replacement per hour to maintain the aeration chamber being clot-free. But yeah, the dose was maintained. So all patients received 30 mils per kilo per hour, and I have the data to support that. But that's only while treatment was on board. So it was 30 mils per kilo whilst being treated.
Right, we've got time for one last quick question.
Great, thanks. Can you go back to your outcomes slide with the 3 categories of outcomes really quick? So I just want to say thank you for your presentation. I think this work is very impactful and needed. But I'm going to ask you a tough question. So presumably the nurses have to respond to advisory and caution and warning alarms, correct?
It comes up as a different sort of alert. So it's more of an orange alert, and they don't have to respond instantly. So the advisory one is like the bag is due for change in half an hour. It self-resolves. It stops itself.
Okay. So my question, and again, I think this is impactful work that you should continue, but I'm curious, did you present these results to the nursing staff, and did they find this change in total alarms per hour clinically meaningful? Because one of the issues with big data, and I'm a fan of big data, is that we can find statistically significant signals that aren't necessarily clinically meaningful.
So indeed, in this data set, there were lots of different signals to be found, and sometimes it's difficult to tease out what is important, but actually, anecdotally, when you talk to the nurses, what do they care the most about? It's the thing that's alarming all the time. I mean, bag changes, yes, which the advisory alarms also indicate, actually, but it's more than the odd negative pressure or something you might find statistically significant in a numerical value, but this is an incident event that the machine alarms for. To a certain degree, the alarms are set by the nursing staff, so they can reset them to a different operating point for some of the alarms. So that's one thing that can change, but generally their practices were unchanged from the before and after in this case. But the warning alarms are actually the thing that the nursing staff seem to be the most concerned about.
Thank you very much, Ben.